Yeah.
Well, welcome everyone. It's Sunday morning. We all know when it's Sunday, it's Meet the Press. I'm Dan Kester. I'm filling in for Chuck Todd this morning. Our special guests on Meet the Press today are Vice President Joe Biden, President Donald Trump, Joe Freudenheim, and Mimi Frisch. Glad you could join us. I'm going to introduce our first two speakers. Mimi Frisch, who you see on your left, unless you have your screen reversed, with a coffee cup, has worked for
Dan, you're muted.
Oh, how'd that? Oh, unmuted. So Mimi has worked in Africa, in Rwanda and Liberia for 3 years in public health. Currently works for the University of Global Health Equity in Rwanda, doing research with Partners in Health. She'll talk more about what she's doing, but is working, my understanding is going to be working on contact finding, people who have the virus, to find their contacts and identify those and hopefully minimize the spread. Joe Freudenheim happens to be Mimi's mother. She is a longtime epidemiologist and is chair of the Department of Epidemiology at UB. And I've heard that she has just become a distinguished professor. So we're very honored to have both of you here, and I will turn it over to you.
Great, thanks. Yeah, so we're thrilled to do this. You know who we are, and it's really great to see all of your faces. So we wanted to, you know, there's so much in the news about epidemiology. Epidemiology is something that mostly people have never heard of, but that's not the case at all in the last couple of months. And so we thought that it might be interesting for you to hear from us about what epidemiology really is and what epidemiologists do. And then Miriam also is going to talk really specifically about her experiences in public health outside of the United States, because I think there's a lot we know within the US that we don't know about what's going on outside the US. So just to be clear, you know, we're joined here by Mike Frisch, who many of you know, who is connected. Who is also part of the whole epidemiology enterprise.
It's a family affair now.
Yeah. So we're gonna, first I'll talk a little bit about epidemiology. I'm an academic doing epidemiology, and Miriam's been more involved in public health practice, and so she'll talk about that. So just to start, there is kind of a separation in epidemiology. Epidemiology is looking at populations to understand what causes disease, who's more likely to get disease, and how to prevent it. Is that us? No. Okay. So I'm an infectious disease epidemiology. I look at
You're not infectious disease.
Sorry, yeah, I'm a chronic disease epidemiologist, and so most of my work is on cancer. So I speak of infectious disease. I have less knowledge about infectious disease epidemiology, although I've learned a lot more about it in the last few weeks. When I started in epidemiology, there was more or less an assumption that we knew everything we needed to know about infectious disease, and then infectious diseases were more or less on the wane, which is a silly perspective from that we know now. So epidemiologists work on study design. They try and understand how to set up a good study, how to, and then they collect the data, they analyze data, and then they interpret it. But again, it's always looking less. So whereas medicine is focused more on a single individual, epidemiology is more focused on looking at a whole population. And there are different kinds of pieces to that work. One part is surveillance, We've heard a lot about surveillance with the COVID outbreak, trying to understand how many people have gotten the disease, how many people have died of the disease. And as we've seen, that's a complicated question that it's harder than you would think to even to do a count when you look at the whole population. This morning I was reading an article about how even the counts of how many people have flu and how many people have died of flu are all based on estimates, that there's an algorithm where how many do we actually know that we've seen, and then they have an algorithm to estimate how many there were based on that. And so surveillance is all about counting and trying to identify when there is an unusual number of anything. So we look at, in cancer, we look for clusters. Sometimes all of a sudden you see a large number of people with a certain kind of cancer living in a certain area or working in a particular industry. And that tells us something about who, maybe understanding better how to prevent that disease. The next kind of general piece of epidemiology are observational studies. So we measure things about people's habits and about who they are, and then try to see who among that group get the disease. And so that's being done now with the COVID pandemic. We have existing cohorts, groups of people where we have a ton of information about what their lives are usually like, and those same people now are being contacted to see who got the disease and also who got severe disease. So to understand, does it make it worse if you're a smoker? Does it make it, we know from China, we've seen some evidence that it's worse for smokers, it's worse for men than women, but there's a lot that we don't really understand about how that's playing out in the United States. So they're using existing studies to try and put the two pieces together to get more information about how to prevent the worst outcomes for COVID. And then a big other part of epidemiology is what are called clinical trials. And you've heard a lot about the need for good clinical trials in order to figure out what drugs work and don't work. So a clinical trial is one where, rather than just watching people in their lives and seeing what happens, people are actually randomized and they're given a particular exposure. And in this case, some people get a particular drug and other people get a placebo. And so then you can tell really what the impact is of that drug because you have the groups are the same because they've been randomized in terms of other qualities. And I think I'll stop there and I'll turn it over to Mimi.
Yeah. Hi, everyone. It's great to be here. So as Dan introduced, my background has mostly been in public health practice. I graduated from Pitt in 2015, and I've been working in global health pretty much since. I've spent 2 years in Rwanda and then 1 year in Liberia, and then interspersed in that some work in the US as well. And I will be going to medical school in the fall. So thanks. So I think kind of the ways that we are thinking of framing my part of the talk is I can talk a little bit about my experiences, but also something about how kind of all of these things are from practice or from like theory are now really being put into practice. And in many ways for me, I think coming from a global health background, what's so exciting, or not exciting, but really interesting about this current pandemic is that we generally think about how global health is kind of like what you would imagine as like treating people in rural Africa or taking care of poor people in like, very underserved poor countries. But in reality, global health is like everything that we're doing right now. Like global health means, really prioritizing the care of every single person and understanding that the health of like me or my mom is also impacting and like, connected to the health of everyone around us. And so I think that something that has kind of, especially from my background, become clear now is that we are seeing that like we can't necessarily be thinking of health in silos, and we can't necessarily be thinking of like US health and then health in Africa. And especially what's been interesting and what I'll just briefly talk about is how so much of like what has happened in the past in health in sub-Saharan Africa, for instance, Ebola and malaria and things like that, have really in many ways put those countries in a better sense of preparedness for COVID than we are in the United States, because these governments and public health systems are used to dealing with infectious diseases, right? Like, you know, they don't have the perception that infectious diseases are on their way out. They're dealing with them every day, and their populations are also used to understanding that. So that's kind of like a brief overview. I'm currently working for the University of Global Health Equity, which is based in Rwanda, and they are a medical school, actually. That's an initiative of Partners in Health, and Partners in Health is a global health large nonprofit organization. And basically the belief of UGHE is that we need to be training medical students, but also master's students who are in the country that they're working in. So it's based in Rwanda. It's primarily training Rwandans and other people from sub-Saharan Africa, and giving them expertise to really be strengthening health systems in those countries with attention to equity. So just kind of as a brief background, a big term that's, you know, a buzzword now in global health is equity. And whereas we think of equality kind of as giving everyone the same opportunities, equity is like understanding that, you know, people from a poor rural village in Rwanda like need more support in order to have, you know, the same success. You know, so we need to be giving more social support to people to really be providing them with the same opportunities that someone in a city might have. So I've been doing research with them mostly on under 5 childhood mortality. So understanding kind of not only what countries are doing that has made like their under 5 childhood mortality rates pretty high, so like what's going wrong, but really doing kind of an alternative flip approach of understanding what's going right in countries, and like understanding how countries who've been able to really reduce mortality, how they did that effectively. And I think that looking at the COVID outbreak, now we see so much of public health is all interconnected, and people from every single scope, myself included, are being pulled into COVID work, even though that is not necessarily our backgrounds. And I've really been working a lot with people to try and think about how we can be using this approach of studying what is going right in places and using that as a lesson rather than focusing on what's going wrong. Because if you kind of have effective understandings of what's going right, you can leverage that. So kind of going off of that, I'll talk a little bit about what I think Rwanda is doing really right in this epidemic that's actually much more impressive compared to the United States. And then I'll also talk a little bit about the work that I've been doing with Partners in Health around COVID. So Rwanda, just as a little bit of background, is a country that you may have heard of from the Rwandan genocide that happened in 1994 with the genocide against the Tutsis. So Hotel Rwanda, if you're familiar with that, over 1 million people died in roughly 100 days. It was like a really horrible atrocity. But the incredible thing with Rwanda is how much they've transformed since. So in 26 years since that Rwandan genocide, maternal mortality rates have dropped by 75%. Under childhood mortality rates have decreased by 80%. The life expectancy has tripled, and GDP has increased from $200 per capita per year to like 800. So that's still pretty meager considering the rest of the world. I think in the United States, it's like 40,000 or something, like maybe even higher, 50,000. But considering that, Rwanda has done really incredible things with still having a pretty poor population. They have a really strong, effective government, and they really approach things with like an evidence-based and an equity-based approach. So it's like a very incredibly organized country. It's the cleanest place I've ever been and ever lived. Like the streets are immaculate. Everyone, you know, it does not meet your perception of what you would expect for Africa whatsoever, which I think is great. It's kind of pushing those understandings. So in Rwanda, they, beginning in January, started doing screenings at the airports for COVID. So every single person who came in had a temperature check, and they asked you if you've currently been to, recently been to China, you have a fever, do you have like sore throat, do you know anyone who's had COVID? And keep in mind, this was in January. Like, this was before anyone in the United States was even thinking about doing this stuff. And if anyone had suspected at that time, they were starting to test. So it was really very early on that they were doing testing and tracing. Beginning, it was March 16th, which was like right around the same week that things were really ramping up in the United States. Rwanda had its first case of COVID. So just kind of as a timeline, I think the first case in the United States with all the cruises and everything was like late January, maybe sometime in mid-February at the latest. So here's Rwanda, which is about a month later than that. $800 per capita, like pretty still not a ton of money. March 16th, they had their first case. That same day, they closed all of the schools, all of the churches. So this was a Saturday, so no religious centers were open the following day. They stopped all public gatherings. They said any non-essential employees should start working from home effective Monday. They were requiring anyone who enters into any public building to sanitize out front. So like almost immediately overnight, there was hand sanitizer out front of every single store. And that was like in one day. Then
in the buses too.
Yeah, and then the buses, and you were required to keep like 6 feet different distance from everyone on buses. So that was on Saturday. And then because I was going to medical school, I actually decided that in reality, I would have been safer to be in Rwanda than I was here in the US. But because of what was shortly announced after, which is that they were closing their borders, I decided that I needed to kind of leave. So just to be back in the States because their borders are still closed. But so that was Saturday. And then Wednesday night, they announced that all of their borders were closing except for like essential like movements of like trucks and stuff bringing essential cargo. So all of their flights out of the country were ending 48 hours after that. They stopped all movement between borders. They stopped all movements between regions of the country. So especially with a disease like COVID, it was really being brought in by travelers. And in a place like Rwanda, where you have a big city like Kigali, which is very cosmopolitan, you also have a lot of really small rural villages that would just be totally decimated if the disease got there, and it'd be impossible to trace. So they wanted to make sure that they're keeping anyone who has the disease or is any risk to be in the city. So then they stopped all of that, and then they put the country in complete lockdown. So for a month, no one was allowed to leave their compounds unless they were going to get groceries. There was only one person allowed per car. So only one member of your family was allowed to leave. You had to have like transport permission so that if you like needed to go, my friend had to like take a taxi someplace, and it was like a whole nightmare for him to like move from one place to another. And so they were all these really impressive social restrictions, and they were doing a ton of contact tracing and testing. So they traced every single contact of every single case. And because of all of these things put together, it became this really effective operation. So as of today, I think they have 242 confirmed cases. They've tested on average about 1,500 people a day. They have had no deaths. They've had I think no critical cases whatsoever. The majority of the confirmed cases are asymptomatic, and they've been monitoring and tracing all of the contacts. So it's not only that they're pulling people who are asymptomatic out of their homes and putting them in hotels or hospitals where they're being monitored, but they're also pulling out contacts. And if you have been like a close contact, so that means spending an extended period of time, like my mom and I right now would be contacts, you would be going into a hotel and you would be monitored as well. And same with any travelers who are coming in during that time. We're required to quarantine for 14 days in a hotel. So I think that that's, like, they learned those lessons because they were following what everyone in public health now is calling epidemiology 101, like the very basics of epidemiology. And they also were using their experiences from Ebola and from malaria and understanding what contact tracing is. And I think that that's a really important lesson for us to kind of change our mindsets now, is that thinking that, you know, the United States, it's like the best thing, you know, like the best country and has the best practices that everyone can learn from. And in reality now that's the opposite. And so that's something that my organization, Partners in Health, is the like parent, you know, or co-organization that works with University of Global Health Equity. And I have worked with them in Liberia. They work in 10 countries around the world. And their major focus is on health system strengthening and really kind of building out high quality care in low resource settings so that people are getting like really, you know, solid care and that it's in a sustainable way. So focusing on community health and hospitals and social support all kind of together. And so I think the really exciting thing, and I'm only going to take 1 more minute, is talking about how Partners in Health was asked to start implementing a lot of the lessons that they learned in Rwanda and Sierra Leone and Liberia and Malawi to work in Massachusetts. So they signed a $40 million agreement with the governor of Massachusetts to run a contact tracing initiative there, where they have, over a span of 3 weeks, brought on over 1,000 contact tracers and a cohort of like, I think, over 1,200 people to do the same things that I've been talking about of contact tracing in the United States. And so I think that that is really kind of like how things have changed. I see a question of what is Rwanda's population? 12 million people. It's actually one of the most densely populated countries in the world. Fun fact. But yeah, I think that that's kind of like the big lesson that is important to think about. And so you hear about a lot of countries like New Zealand doing well and, you know, like these high resource settings, but also Rwanda is doing incredibly well and they're opening up tomorrow. So they are going to be starting to allow people to go back to work, and there's a curfew and they're doing it in a very set way, but they have had a plan, they've stuck by it, they've used evidence, and it's been effective.
So when, just one thing in the Massachusetts project that they've used the that same model, that not only are they tracing contacts, but they're for people. So there's some people, you say you've been exposed to COVID, you need to stay home for 2 weeks, and they can't do that. And what part of this whole initiative in Massachusetts is then they figure out ways to make it so that they can stay home. You know, if they need resources, if they need childcare, if they need, so this kind of bigger picture approach rather than just saying, you need to do this and then ignoring the consequences of that.
Yeah, so that's a really good, like having social support is a really big part of understanding that everyone isn't going to be able to, you know, quarantine in their homes without food or without, you know, like money. And so PIH's real focus is like thinking about health. You're not going to have people going to the hospital if like they don't even have food to put on their table that day. And so, you know, really thinking of it as a more holistic way.
So we're open to questions.
Ask away. I don't know how you guys want to do the...
I have a question.
Sure.
Hello?
Yes.
Hi, this is Sheila Bernard. I have a question more about the spreading of the coronavirus. I am concerned over, well, I'm concerned over every way that I could possibly, or my family or friends, catch it. But now that we're all going outdoors, is there a remote possibility that if you get stung by a bee who stung somebody or bit somebody, or any of the flying insects or creepy crawly ones, if they have come in contact and have bitten somebody with corona and they come along like a mosquito and bite you, is that a way that you can also have the disease transmitted to you?
So my knowledge is, and again, I'm not an expert on this whatsoever, so we can educate. I'm going to medical school, but I won't have any medical knowledge for like 6 more years. But I think really like the concern with coronavirus is that it's an airborne or like a droplet spread. So like really the way you're gonna get sick from it is if you're breathing in the air droplets and the virus from someone else and it gets into your lungs. So that's why, you know, coughing and pneumonia are the major symptoms is because it's caught from that. So I think really like I don't know if like, I don't believe that it's the same kind of transmission that you would have from malaria for a mosquito. Don't quote me on that. There's also still a lot we're learning
so much
and we don't know. Like, you know, this is every day they're coming out with new things. But I think, you know, if you had to choose between being really concerned about getting bit by a mosquito or, you know, by like wearing a mask and standing more than 6 feet away, I would definitely prioritize social. I think it's.
I guess that includes the killer bees that are around us now too. Right? Thank you.
Miriam?
Yeah, this is Barry Heckner. I have a question. With a large number of active cases, 2,000 per day that they're finding, isn't that too many for contact tracing?
So that's why you hire a lot of people. So they did a modeling of looking at how many people that they needed to hire to do contact tracing. They hired, on average, a number of people that they
There's a way to raise your
thought they would need to be able to track all of the people. So the way that they calculated the number that they would need was based on the assumption that everyone had between like 5 to 10 contacts. So actually what they found is that they don't need that many. The average number of people, because of all of the social distancing, most people who have COVID are only coming in contact with around 2 other people. So that's really good. But really, like, you know, yes, you need 2,000 people a day, but that also think about it kind of as like a, you know, economic stimulus is how Massachusetts is doing it. You have 2,000 people a day getting COVID or whatever the new cases are, but you're also having, I think it's what, like 30 million people now are unemployed in the United States. So, you know, if you are giving each of those people, you know, like a link on their computer, well, they will be able to call people and like be employed for that. All of the people from Partners in Health are getting paid, and they're getting paid like wild. Contact tracers are average like $25 an hour, and they're getting health insurance. So this is not just something that they're like getting volunteers, but this is really a way to get the economy back on track. And yeah, it's an ambitious thing to contact all those people, but it's also, you have to do it. Like there's no other way. Like as we open up the economy, the only way that we're going to be able to start having people going around and communicating is if you're able to find the cases, you're finding all of their contacts, you're like pulling them all out of society. And, you know, that's how everyone's going to be able to get back to a normal life.
Yeah,
Thank
so
you.
for 2 weeks, not
For
forever.
2 weeks, right, yeah.
Thank you.
How did in Rwanda, how did the GMP change and the unemployment rate change in those 3 months?
That's a great question. So I think like the unemployment, I don't know if they are necessarily approaching it in the same way as like an unemployment rate. I think that, you know, like those people, just like in the United States, were out of work. I don't technically know if they were considered unemployed. What the Rwandan government did do was for the month of April, they gave all of like the parliament and all of like the high level government leaders like forfeited their salary for a month. And so all of that money went to providing food support for people. So I think I'm positive, I don't know the numbers honestly, about how the GNP was affected and how unemployment was affected. And that was really a main consideration in opening Rwanda up, was because like truly people just can't survive if they're staying at home, especially subsistence farmers and everything. And so that's really why they took even much more of an aggressive approach on that.
Was there any protest to open up?
Protests on opening up? No. Rwanda is, it's a really interesting country in that culturally there's a huge following around the president. There's, you know, like very, like 99% acceptance rate of the president. So take that as you will, kind of in terms of like very, very controlling, but also like very like a benevolent leader. And so people are really trusting of the government. It has like the highest rate of trust of the population, the government in the world, or one of the highest. And people like believe their leaders. And
they also have the highest number of women in parliament of any place in the world. Phil, did you have a question?
I do. Miriam, thank you for your presentation this morning. I think when you left for Africa a few years ago, you thought you were leaving a modern industrialized country and going to a third world country. And like many of these overseas experiences, it enlightens you to the strengths and weaknesses of our own country. So I have a couple questions for you. Did the Ebola epidemic affect how Rwanda reacted to COVID? Sounds like they had their attention. They had the public health infrastructure in place. After seeing what's happened here and realizing that we need all these contact tracers and public health people, how would you feel about a mandatory service corps for all college-age kids for a couple years to do a transition and get some life experience before they actually go out to work? And what medical school are you starting in the fall?
So I'll start with the easiest question. I'm actually going to the ICANN School of Medicine at Mount Sinai. So I'm interested in infectious disease, so it'll be a cool place to be right now.
A really cool place, but I want to tell you, my daughter did the same thing to me. She had a UB acceptance and decided instead to go to the most expensive medical school in the country. So my admiration to your parents.
Yeah, so I think in answer to the service core question, I think that's a great idea. My personal hope from all of this is that what it really transforms for the United States is into much more of a community health focus. So really putting community health workers or, community health centers and more of, a, focus on community health into the community, into like places rather than having more of a private healthcare system. I love the idea of a public health corps. I think it just needs to be really well organized, and we're really making sure that people have the skills or are trained to do really effective things. And there was actually an editorial in the Journal of American Medicine, JAMA, that was suggesting that all of the 20,000 incoming first-year medical students are transitioned to becoming contact tracers for a year, and that's just really key.
One of the reasons why that would be so important is we don't know what the hell to do with the medical students right now. They're like sitting at home. We can teach them distance learning, but I teach freshman anatomy, and we're struggling how to give you a anatomy lab experience that resembles anything like it was last year.
Yeah, I think it's going to be really interesting to see how medical education changes and how all of this, from as someone who's been in a public health background who's now transitioning into medicine and always kind of faced questions of why, how is public health, do you think, important in informing your medical career? I'm in some ways thrilled that now this is really an excuse for medical curriculums to be changing, to be focusing more on public health and understanding that you cannot be effectively treating patients if you're not understanding the society that they're in now.
So I also hope that out of this comes more investment in public health systems. So over the last, it's been quite some time. It's not just the last couple of years. There's been a decrease in investment in public health systems. And, the thing about prevention is you only recognize how when it works, you don't see it. So if you effectively prevented something, then everybody's sort of like, well, there was no problem, right? And in fact, that's not the case at all. It's your prevention was effective. So I think it's been hard to understand why it's important to have public health departments and why it's important to have increased strength in the CDC. And we're seeing now the extent to which those departments have been decimated and don't have the resources that they need.
A couple of questions on the chat. Are you seeing those?
We can see. So let's, how do countries inform other countries of best practices? Did Rwanda inform other countries of how to positively cope with this pandemic from a public health perspective? So it's kind of goes in different ways. A lot of it is through publications. So
There's a chat.
is the best way to kind of educate people.
I don't see change. Tap on the three dots at the upper right.
There's also,
People go on mute.
there's a couple people who might not be, there we go. So there's like peer-reviewed publications is a huge thing. So like the New England Journal of Medicine and others are starting to like release, you know, updates like much more regularly, you know, on COVID and like, you know, pre-reads of papers. Rwanda's also just been working with other countries in the East African community, which is, you know, like an economic community. And so they're really coordinating efforts and sharing lessons learned. I think it's kind of, it's not necessarily in a fully formal way, but there is a lot of knowledge sharing going on.
So there are a couple of questions about testing and contact tracing. So ideally, to do contact tracing, you do a lot of testing. In this country, we've seen this big problem with there not being enough tests. Part of that is because of some bad decisions that were made early on, but and some big errors that were made early on. But it is possible, you know, so contact tracing is a very old technique. You know, people have been doing that for a very long time, and even before there were tests available. So you say, okay, this person has it, and who have they been in contact with, and those people should self-seclude for this amount of time. But ideally, you would also test those people, and there is now testing available in Erie County in this region, but you know, so the more you can test. So the problem, one of the issues with the COVID virus is that there are people who have the virus and don't show symptoms, and there is transmission of the virus even among people who develop symptoms in several days before their symptoms show up. And so there is this problem of passing even, you know, you don't have to rely. So there's all this emphasis on taking people's temperature, which makes sense, but it doesn't, it's not
enough.
Right.
By any means. Yes, there's a question.
Jump in here. Thank you both very much for doing this. We really appreciate it. One of the things that is so confusing about contact tracing and testing for me is that the question is what kind of testing? I mean, testing when somebody is symptomatic, people, I understand now from recent literature that people who have had the disease and are asymptomatic still shed virus up to even 4 weeks. So the issue is, when do you test people? Do you test with is antibody testing more effective than symptomatic testing in order to do contact tracing and provide the information that's needed to control this?
You have a good answer to that?
Yeah. So now we're getting, you know, your understanding may be as good as mine. That's not really my area of expertise. So my understanding is that the antibody tracing is still very much under development, that it's not accurate a fair amount of the time. As for people who are shedding virus even when they don't have symptoms, so to know who has it, you know, so the antibody testing is going to happen more as they move out of the symptomatic phase, or, you know, or it should show up even when they're no longer shedding virus. So that's more to the idea that people have been proposing with the antibody testing, is that that's a way to identify people who perhaps can move around without worrying about getting the virus. But even there, we're not sure how long the antibodies will persist. It's a new disease and everybody's still figuring it out. There's a lot that's not known.
Well, and so that's really why I think doing the like the nasal swabs or, like the testing while you're sick is important, but that's why so many of the public health measures are also really important, right? So like, you don't know necessarily if you've come in contact with someone who's asymptomatic, and they might not be, but if you're all staying 6 feet apart, if you're not touching your face and you're sanitizing your hands, you're wearing a mask wherever it's possible, you're just limiting the like options to be in contact and to get the virus. And so why obviously that's not ideal for everything in general, testing really comes together with contact tracing and social distancing measures, but we're still learning about it. And so the most you can do often is just kind of be taking as many of those measures. And then, if someone tells you, you should get tested, then it's taking it from there.
Could you comment on the Swedish model of dealing with this?
Oh, do you want to comment?
Yeah, I know a little bit. I don't know more than, other people have read in the newspaper,
Yeah.
So the Swedes have really taken a more relaxed approach, but they're getting lots of cases as a result. So when people let people interact more, there's going to be more deaths. That's the unfortunate part of it.
I think one thing that's interesting about the Swedish model, and this has been, I think, more of a problem in the US as we've been seeing, is that really we see countries that have more trust in their governments, or really are listening to more of like what is being said from a public health perspective. Like countries can have more of a different impact on things. So for instance, like in the United States, it's a little bit harder for like people, as we see, like with protests or whatever, they're not necessarily always like directly and immediately responding. There's a lot of people who are responding to what, public health measures are put out. But, I think in Sweden, it's a different culture and it's a different population and a different relationship between the public and the government that allows them to kind of do, I think, in some ways take different, like it changes how the government has an approach to it. And similar, like in Rwanda, they have an exceptional trust. So when they say lockdown, people lock down. And when they say open, but everyone has to wear masks, people trust the government and what they say. And so they'll wear masks. I think that a model like, the Swedish, I think it's shown to be more, like it's not, I don't know enough about it to comment, but,
Yeah.
But it's, I think, like a different scenario because you have a different population.
Quick question. Politics aside, obviously we're seeing just this patchwork of plans and policies and how various states are moving forward and all of that. And it's all over the place. I saw a story over the weekend that the city in Oklahoma decided, okay, we won't require people to wear masks when they go into stores because the customers were threatening the employees. But I have a friend who works for a major employer here in Western New York, and they've been told that when they go back to work, it will be obviously whatever the limits are on their staffing, whether it's you can go back with 25% of the workforce or whatever, but when they go back, even if it's not required by the state, their employees will be required to wear masks all day at work. So it's all over the place. But I mean, what does your gut tell you in terms of when we go back out in public, when the pause is lifted and we start going back to work in a non-essential business, or when we can start having services at Temple in some capacity and things like that, you think we're all going to be wearing masks at that point? And should we?
So, we've been talking about how in Asia, it's just very common for people to wear masks. There's just more of a cultural acceptance of it. And not that it's inherently an Asian culture, but that for the last decade or more, people just wear masks very frequently. And so I think there may come in the US, a kind of an acclimation to it. Partly you see all these different approaches, and that's partly because of what people are philosophical differences or what they're emphasizing one part over another. But I think also it's because we really don't know. there's so much we don't know. Does it really make a difference to sanitize the cans in that you bring from the grocery store? Is that really something that's important, or it's not important? We really don't know that. So there's a little bit of evidence that virus can stay on hard surfaces, but when we're talking about cans from the grocery store, does it really make a difference? And I think there's still a lot to come to understand. So I'm at UB, and there's like all these discussions, like Phil was saying, about how to teach anatomy, or how to teach classes. Can we have classes of a small number of people? So there's all this stuff to talk about, groups of only 50. Well, 50 is a big number. If one person in that group of 50 is infected, that's a lot of people who could get exposed. And so that's not clear to me that is rational as a limitation. There's even discussion about, is 6 feet far enough, or should it be more like 10 or 12 feet? And so there's just so much to understand that it's a brand new disease. If you think about it, it really, the first cases were in December.
End of December.
Yeah. So, and there's been a remarkable amount, so science is in such a different place than it was, say, 100 years ago during the Spanish flu. There's a remarkable amount that we know, but still so much that we really don't know.
There are two questions on chat. One is, can it be spread through food? And the other one is, how come India with 1 billion people has managed to keep their numbers so low?
For India, I think it's actually been a really interesting discussion all around, which is same in Africa, that there's been in some ways fewer cases than we were expecting it to be. So a lot of it is that they don't have the same testing capacity, or there's, not necessarily the same contact testing capacity that there would be in the US, where there's so many more, just more availability and more of a sense of that. There's also, and this is truly just I don't know the data behind it, there's some thoughts around that countries that are doing a more complete vaccination against a lot of different infectious diseases have some more protection. And again, this is, please, these are some few preliminary papers, but it's been an interesting thought that's been passed around, is that for some of Africa and India, that countries that have way more vaccinations that they're giving their children have some sort of cross protection for COVID. So they're vaccinating for diseases that we've never seen in the United States. So we don't get those vaccinations. And so there's intrigue and looking around into that. That's something that I just find is a fascinating theory. I don't know if that's the case, but it's an alternative to just, the revert thought of that there's no testing there. In terms of the food thing, what I've read, and this is mostly just similar lay literature, is that it's not nearly to the highest risk as it is for airborne. It's very, very low likelihood, right?
Yeah, so I suppose if somebody who had COVID coughed all over your food, you could get it.
Right.
But in terms of restaurant food, there's all kinds of normal preventive activities in restaurants, and the restaurants then are for the most part acting at an even higher level than usual. And then again, and I talked about, the thing about, could you get it from your canned food or, other things that you bring into your house? And perhaps, to me, I think the higher priority is the social distancing probably is going to have
washing
a bigger,
your hands. But,
could there be low probability events? Is the probability 0? Yeah, we don't know that. Ruth?
I had a question.
Oh, go ahead.
I had a friend who passed away this past week of the virus. And the question is it be likely that they'll do contact tracing either as to how he got the virus or whether he shared it with other people? Do you have any idea about that?
So I think it depends on the capacity for the contact tracing. I think, you know, I think New York State is like still, there's a lot of like talk right now about how New York State is going to start doing more intensive contact tracing. I think in an ideal world, yeah, you would be doing the like, you know, tracing the contacts of who, you know, that person has been in contact with. But now I don't know if that's.
So I know Erie County is doing that. They have, you know, not a huge capacity. I think there are 3 epidemiologists in the whole Erie County Department of Health. And they, you know, so Gail Burstein, who's a member of our congregation, is the commissioner of health. They're working really hard to do as much contact tracing as they can. I don't know whether they go back. I would assume that they are to try and understand how, less where the person got it from, but who else they may have been in contact with.
Can I just say, whoever just made that comment, I guess it was Bruce, the people who came in contact with that person should self-isolate themselves or quarantine themselves for 14 days. Yeah. And if they remain asymptomatic, praise God. But if they get sick, then they need to go get help. But the people who know that they were in contact with that person who just died of COVID should quarantine themselves for 14 days. They don't need a public health doctor to tell them to do it.
Yeah. Yeah. And I think that is a good point too about, you know, if you know, I think there was a question about if you know someone who's had it, but you don't have any symptoms and you're asymptomatic, you should definitely be quarantined. I think, you know, really thinking about limiting the number of places you're going to limit your risk, but also recognizing, you know, like if you know anyone or if you yourself get sick, like, you know, yes, contact tracing is so important, but it's also important that you're telling those people as well. You know, this is really a disease where we're kind of all in it together, and that's how, you know, we have to rely on the public health support, but we also have to rely on each other. You know, so I flew back from Rwanda to the United States and I quarantined for 14 days. You know, like, I think it's just, we have to all be doing our part. It's a good point, Bill.
And also, and Bruce, we're just so sorry for that loss. For your loss.
So sorry. Yeah.
Thank you. Thank you.
I think Ruth had a question.
Yeah. So that's actually a personal question. I was in contact with somebody about a week before they tested positive for COVID. They had to go to the hospital. They tested negative when they went into the hospital, and then we're going to get transferred to a rehab facility, and they did the COVID test and they tested positive. They were asymptomatic. So that was about 9 or 10 days ago for me. I'm asymptomatic. I'm currently quarantined, but so when I tried to get a test, my primary said testing for me was optional, and I don't know whether it is or not. But when I tried to get a test through Quest, I can't get an appointment till next Friday, which is May 8th. And then they told me that's the antibody test. So, but now I hear there's another test through, well, now the urgent care facility, which would show if you're, you know, if you're positive before, but I'm asymptomatic. So I don't know if I should get tested or not, or if I should go to WellCare or wait 14 days, or it would be like 16 days and go get tested to see if I developed antibodies.
Okay, so we're not doctors.
And my primary said it was totally optional whether I got tested at all.
So if you're still, you're self-quarantining and you're in that period of that 14 days. And if it makes sense, as Phil was saying, for you to self-quarantine for that 14 days because you've been in contact with this person who tested positive. By doing the antibody test to the extent that it's accurate, that would give you information about whether or not you had it during that 14 days. And that would be useful information for you to have.
And same if you did the urgent care nasal swab one.
But should I do that if I'm still asymptomatic and, you know, like try to get in on Monday or Tuesday? You know,
I don't know, like, so you're still gonna, like, if you're asymptomatic, you're still gonna test, like, it's still gonna show up in your, like, in the test if it's positive or negative. I was reading some interesting things that were, and again, I'm, like, truly not experts whatsoever, that are saying that, like, really one of the crazy things about COVID is that, you know, like, it can be showing up in your body for a long time and people don't have any problems. And then some of the people who get really sick all of a sudden just get really sick, you know? And so I don't think that that's gonna be, you know, but I think there is, it doesn't, you would still test positive if you're asymptomatic for either.
If you have it.
If you have it. But I think the best thing you can be doing is self-quarantining. But again, I'm not others.
I have a more general question to ask. And thank you both for sharing your experience with us. And my question is for Miriam, considering your experience in Rwanda and seeing how the healthcare system works there, what do you think are the most important changes we can make here to make our healthcare system more effective?
I think there's a lot of things. I think the first thing, like a true, like, you know, a universal health coverage system. I think that it just really, you have to make, like, you know, healthcare affordable, and you have to be guaranteeing health insurance for everyone. I think that beyond anything else, you need that because, you know, as we see in Rwanda and we see in other places, like, if you have improved preventative healthcare, you're going to have better health, and it's going to reduce the costs and the burden on the healthcare system for, like, curative healthcare. So if you have more of a universal health coverage system, that means that people are going to be able to go to their primary care doctor when they're feeling like they have a cold, you know, and not necessarily when they are showing up, you know, 4 days later to the emergency room with pneumonia and then causing, you know, the health system a lot more money and burden. And so I think that that's really, having a universal health coverage system is so much more cost effective and really, like, resource effective in terms of our health resources. And I think that makes a lot of sense.
You want to talk about the community health workers?
Yeah. So in Rwanda, there are a cadre of 45,000 community health workers. So there's 60,000, 4 for every village. And every village has about 100 families. And so those community health workers are really responsible for knowing those communities and going, and when a woman is pregnant, you know, they'll go and do antenatal care checkups on them, making sure that they're going to the health clinic to receive more care, you know, reporting data on what, you know, the health is like, doing nutrition checkups for kids who are under 5, and also educating the populations on, you know, like, health issues, and doing kind of education and sensitization, and supporting with vaccinations and stuff. And I think that there's so much in the United States of, like, you know, you're either healthy or, like, you know, you might go to your doctor, or you might really, you know, you're really sick enough and going to the hospital, and there's not as much of a community health focus. And I think that that's really important, just to get people to have more trust and understanding of the health system too, especially for vulnerable and low resource communities. I think that, like, to be honest with you, I can explain a few other countries' health systems in much more clarity than I can the American healthcare system. Like, I truly just still struggle to completely understand how it works compared to very clear public versus private healthcare systems in other countries. So I think that, like, really thinking about how we can make our healthcare systems that they're more affordable, but also really more equitable, and making sure that people who don't know how to access care, who don't have the resources, who are undocumented or poor and, you know, scared or educated on health issues and are receiving care, is, I think, a big step. And we see that, like, that's going to have for COVID too, you know, so many of the people who are getting COVID are not necessarily, like, you know, like, our middle class family who's able to quarantine and work from home from our computers, but people who are homeless, who are, you know, like, you know, lower income and forced to work, who don't have the ability to quarantine. And by providing a health system that is catering to them as well, you're going to have a better health in general of the population.
You're referring to that question about India back, there's an article today in the Times about that there's been a lot of focus on a TB vaccination that was being done that we haven't done here in a long time because we've eliminated TB, and it goes back 100 years. But it seems to have effect against other coviruses and other kinds of viruses.
Yeah, the BCG vaccine. Yeah, I think I read the article that was published, or the study that was released on that a couple weeks ago. And again, it's still like we don't quite know, and there's a lot of.
So, and it doesn't look like it completely eliminates, that it's complete protection. And what I was seeing, it was that it only lasts for a couple of years. It's not a lifetime of protection.
Yeah.
So.
But there is some thought that because of that may be why especially more children are more protected.
And then on a personal question, do you happen to know Kimberly Bohr? She was a CDC epidemiologist in Rwanda to about a year or two ago. Just curious if you knew her. She's a cousin.
No, unfortunately, but maybe I would recognize her face.
Okay.
I have a question. We hear a lot about flattening the curve. And when I think about that, it seems like all that really is doing is postponing people getting sick rather than reducing the number of people who are sick or the number of people who die. Is that correct, or can you comment on that?
So part of the goal of flattening the curve, you're absolutely right, is to delay when people get, maybe you're thinking the same number of people, but over a longer period of time. And the idea there was to avoid the situation that happened in Italy and also in New York City, where the number of cases, the number of sick people was beyond what the health system could handle. And so in Erie County, so far that has not happened. There was a lot of planning. There is somewhat more capacity than there had, beforehand. But so far the number of cases hasn't exceeded what was available in terms of hospital beds and ICU beds. But it's completely true. It's not a beautiful solution. A beautiful solution is then you flatten it and then it goes down faster and you get to where you don't have cases. It looks to me like until there's a vaccine, we're really, we're always going to be dealing with the fact that there's a virus out there that almost all of us have never experienced. Now a small number of, proportion have, and seems to be very contagious and has potentially very high adverse effects.
So if flattening the curve doesn't reduce the number of people getting sick, it seems that as long as you have enough hospital capacity, wouldn't it make sense to let everyone get it and get it over with? Like, do the Georgia idea?
So, yeah, at huge cost. If you do
you
that,
just have so many people who would die.
Yeah. So that's saying we're fine with hundreds of thousands of people dying.
But if flattening the curve only postpones it, then what's the difference?
So then all of those people who are really sick have ability to go to a hospital that has a bed and a ventilator that can take care of them. So if you're having that's why, Cuomo was really pushing for all the ventilators, if you're having everyone get it at once, you just don't have the healthcare workers, you don't have the capacity. Healthcare workers become extremely overworked, they get sick, there's more of them dying, it would just be.
So the other thing about flattening the curve too is that it gives you time to kind of figure out what makes sense and what doesn't make sense. So how do you do an appropriate job of reopening? What size group of people can get together? How far apart should they be? Is a cloth mask good enough in that situation? And there's a lot that we know. There's tons we don't know, but we know a lot more now than we did 2 months ago. And having everybody separate for 2 months allowed that information to come together.
And you really are saving lives too. By flattening the curve, by having everyone stay inside, it means a lot more people who might have gotten it otherwise are not getting it right now, you know, and like the more we learn about things, the more that those people who have not gotten it, like you or I, you know, are still going to be taking in those lessons and not getting it in the future. And that has a really big impact.
Yeah, the other thing is regarding that point that Daniel just mentioned, the Swedish model is basically what you're talking about. And their major health official is saying, let's rely on herd immunity, so that throw everybody into the you know, mix, and let them become immune to the disease, and those that don't, so be it, you know. And our philosophy is much different here than that. I don't think that we
healthcare capacity too in different places, you know, like, but yeah, I think there's just it's a very different approach for different places.
So for herd immunity, my understanding is you need to have 60 to 70% of the people have antibodies. So as bad as it's been in New York, it looks like about 20% have antibodies. So there's still, you know, there's been a huge personal cost in New York City, and they're still only partway to herd immunity. It's a, you know, and if you do something like that, you know, I don't know. I mean,
there would just be so many people who would die. And unfortunately too, it would mean that really it would become even more, in my opinion, to become much more of a class issue too, of the people who can afford to avoid it and to stay home and to access private health care, or who have access to tests, and, you know, poor and elderly people are not. And I think that's an unfortunate benefit.
Also, flattening the curve gives us some time, for example, to find treatments.
Yeah, that's what.
Yeah, Amy O'Donnell just made that same point. You know, and for sure, the approach to treatment has improved. And you know, there was a lot that was learned in China in the 2 months that they worked on it, and within the United States, there's been a lot of movement about what to look for and what matters, just within a couple of weeks, really.
And if you think about the herd immunity, you're talking about 60% of the American people, which would be around 200 million people. And if you have a 1%, just say you have a 1% fatality on that, you're talking about 2 million deaths.
Yeah.
And I'm not sure our country is willing to accept that.
Well, or should they?
Yeah.
It's, yeah. Yep.
In regard to New York City and contact tracing, more than 50 years ago, I lived in New York, and I took 2 subways and 4 bus rides each day. How do you do contact tracing on a person like myself?
So the idea for contact tracing is if you are within 6, you are considered a contact if you're within 6 feet of one person for more than 15 minutes for an extended period of time. So the idea is if you're opening up buses and subways, that you would be like either running a lot more, or like limiting the number of people who are allowed on at a time, so that everyone is standing 6 feet apart from another, so that those wouldn't, and wearing masks and sanitizing, you would not be technically contacts of people when you're on those places.
But in the actual situation, I would not know my contacts and those 3 rides or 6 rides per day.
But theoretically, those wouldn't be your contacts.
Well, but
it's true.
Yeah.
If you're in a situation, and it's part of why we've seen faster transmission in denser situations, is because you have the situation. So in Wuhan, people were not allowed to leave their apartments because the streets in Wuhan are always full. It's really different from Buffalo, where I can walk my dog and see not a single other person. But in Wuhan, there always were, you have crowded sidewalks, lots of people on the street. So when you have that kind of density, there is a much higher likelihood that people are coming in contact with each other. And you're right, it becomes that much more difficult to figure out who that person has had contact with. So now there's all this discussion about apps, so something where if you did this very complicated
geographic trace.
Right. So if everybody has a cell phone in their pocket and they and that cell phone is indicating where they are at all times, that you would be able to see everybody that was on the bus with you.
I have a question. How do you combat this attitude that if you're very successful, like there's been criticisms of, oh, they prepared all this excess hospital beds and ventilators and such, and then they weren't used. Oh, we didn't really need all of that. So going forward, how do you combat that kind of success story? Sort of what you intimated in the beginning. You don't notice when you succeed.
So I have colleagues who are who work in IT. And if you recall, there was that whole thing with Y2K, right? And people went nuts fixing up their computers so that there wouldn't be this huge implosion of some kind or another around the Y2K. And at the end of it, everybody was like, well, nothing happened. And my friends in IT are like, yeah, that's because we worked really, really hard. And that's why nothing happened. And if we hadn't, you wouldn't have had your little computer working the next day for these 600 reasons. And it's the same kind of a thing when prevention really works. So it's interesting to me, even thinking about fundraising. My colleagues at Roswell Park get lots of money from their satisfied or the patients who did well, or the families of patients who didn't do well, because there's this, it's really solid. You see somebody got sick and they were helped. And when you do prevention, you're helping people. When it really works, you don't see it. And I don't have the answer to how you fix that, but I think that so in a situation like this, we start to understand what happens when you don't have it.
Yeah, I think it's going to be using, and that's, I think, why like a lot of these science and evidence-based leadership decisions and saying, look at what happened in Italy, this is what it didn't, and then look at what happened here, this is because. So I think, you'll see, I follow Mark Poloncarz on Twitter, and he's like, it's showing like flattening the curve is working in Erie County, remember this. And so I think that those are, Amy O'Donnell says, at our hospital, they say we prepare for the worst and pray for the best. If you spread that message, then people understand more.
Yep.
I think that's a great way to.
Yep. Yeah, I think that's perfect.
Could you say something about other countries seem to be doing a lot of testing, and in the US, we don't have the tests. It doesn't seem like we do. Why is that? Why can't we? I know they had trouble developing the tests from the CDC, but why can't they just use whatever tests other countries are using?
There's different restrictions around what the United States and CDC and FDA approve. So WHO had thousands and thousands of tests that were like ready and allocated for the United States that the United States said they didn't want.
It's a political screw up, not a medical.
It's partly. So partly the tests are dependent on some reagents that are in somewhat short supply. There was one point, Chris, you probably saw this too, where they were sending out emails saying, does anybody have these reagents? The health department needs them. And, which was just some indication of the extent to which there was, it's partly relying, there's certain things that were the bottleneck.
There's a question that said, what happened to the tests from South Korea? I don't know. I'm currently my background with Partners in Health is with supply chain. And so I'm helping Partners in Health out now with supply chain, and I'm working on some orders from South Korea to go to different places. And what I can tell you is that the logistics right now of getting anything anywhere is a nightmare. And that so we think about okay, you have the tests, but getting flights, and getting cargo on planes and getting them to the United States is a little easier than when you're trying to get something to Lesotho, but it is so hard. So all of these restrictions that places are putting in place, or the economy affecting airlines has huge direct implications on how we're able to transport all of these things. So I don't know directly about the tests from South Korea, but I think, yeah, it's just a very complicated thing all around, unfortunately.
So as an outside observer, it seems really odd to me that we don't have tests in the United States. That's all I can say. I don't really understand what the politics are or the, but it just seems really strange, you know, that there are tests available in other places. But that's not me as an expert. That's just me as a.
Jess had sent in a question. Jess, are you online? Can you ask your question? Maybe she left. I'll read her question. Thanks for your insights. When will you be returning to Rwanda? And can you share something that is bringing you joy amidst this craziness, something that you're looking forward to?
Thank you.
Sure. I will not be returning to Rwanda, unfortunately, right now.
Anytime soon.
Anytime soon. I was scheduled to be there until June, and so that was really the reason that I left, was not because of how Rwanda was handling the crisis, but more because I didn't know if I would be able to leave in time to go to medical school. So I'm still working full-time with my job there, and expect to continue doing some research and work with them throughout medical school. So I'm sure I'll be back at some point. Things that bring me joy right now. I mean, besides like having like bagels and cream cheese at like very close proximity and moving to a city where there'll be a lot of that. I think one thing that's just like interesting from a public health perspective, or like, is this has always been something that me and my mom talk about. Like, we've always been interested in public health. I was like reading about Ebola like way before, like, you know, most people were thinking about it in the United States. But I think that like really getting everyone like talking and interested in public health, and also just like pitching together. Like, when has there been such a global movement when everyone is like staying at home, not just for their own protection, but for other people's protection? And I think that like the United States just historically has been a pretty individualistic society. And I think I'm really curious to see what happens now. And that I think that this is kind of a time where things are going to be reconsidered to like how individualistic we can be, because your individualism affects my individualism and affects my ability to remain healthy. And I think that you know, might be some sort of shift in things that will be interesting. Well, and that's exciting and an optimistic light.
So yeah, that there's not even just within the US, but it's so clear at this point that we are a global people, and that health in Rwanda impacts health in other parts of the world, and that, you know, so I take a special offense to calling this the Chinese virus. It's a virus, and it's affecting all of us all over the world.
And on that note, thank you very much for speaking to us today. Thank you everyone for joining us. We'll have to do this again sometime.
Yeah, thanks
This is
everyone.
great.
This was really fun. Yeah.
Everyone's muted so you can't hear it. Thank you, everyone.
Great questions.
Yeah.
It was awesome. Thank you.
Thank you so much for enlightening us. It was very interesting.
All right.
Good luck in medical school.
Yeah.
We need
Thank
your
you.
brains badly. I tell you. All the best.